So, welcome everybody to this afternoon's training, awareness raising on fetal alcohol spectrum disorder. So today we're going to look at a briefing that's been developed in light of learning that was identified within a recent review in Walsall and in Wolverhampton, which highlighted the need to strengthen awareness and identification of support for children affected by FASD. So we're hoping today that you'll increase your awareness and professional curiosity around the subject, and be able to improve early identification and understanding of the presentation, strengthen the multi-agency response, to promote better outcomes for children and young people, and embed learning from recent local review activity into practice. So throughout the session, we've got three main areas. We'll focus on understanding FASD, including identification and diagnosis. And there's some points there on what we're actually going to focus within that. Impact on children and young people, and a lived experience perspective. So throughout this, we'll be hearing from Dr. Kath Williams, who's the designated doctor for safeguarding children and child death. And she'll explain the first two areas that the session will cover. And the final one, we've got Cindy, who's a parent with lived experience of a child with FASD. And just want to thank you very much for coming to do that, Cindy. It's a privilege for us to hear from you. And following both sessions, there'll be a time for questions. So I'm going to hand over to Kath, who's going to take us through this afternoon's first part.
Just to clarify, Sarah, are you doing all the slides or am I sharing my slides?
Sorry, yeah, I've got it all in one presentation. Yeah,
that's okay.
Just tell me when to move on.
Just so I know what I'm doing. Okay, if you want to go on to the cover slide, then please. Okay, so as Sarah said, I'm the designated doctor for safeguarding children and child death for the ICB, and I cover Wolverhampton and Walsall, and that's the main part of my job. But I'm also a part-time community paediatrician in Wolverhampton, so see a lot of children for neurodevelopmental assessment, and that can include looking for autism, ADHD, and FASD. So I'm not an expert in FASD, but I've come across it plenty in my working life on the front line. I'm sure I've come across it more often than I've recognised it, and there's more and more information out there about it, and the impact it has, and we are seeing it more now in the safeguarding world, in the CPIC world, and I think it's just something that's as important as autism and ADHD to be aware of as multi-agency professionals. So as part of this talk, we're going to be looking at what is fetal alcohol spectrum disorder, how it presents, and then how we go about diagnosing it. I'm going to look at the impact of FASD, as it's known, on children and adolescents, how it's managed, and resources and support for families, for the children and young people, and for involved professionals. Okay, next slide, please. Thank you. So if we're looking at what is FASD, it's a neurodevelopmental diagnosis that can result from alcohol exposure during pregnancy. So it comes from the brain development, and it's a continuum of structural abnormalities. So it's the way the brain is put together, the way the nerves work, the way the communications work within the brain, and it's caused by alcohol exposure during pregnancy. When someone has a problem with FASD, the way they think, the way they learn, and the way they behave can all be affected by the brain abnormalities, but it can also affect other systems of the body. So you can get growth problems, you can get cardiovascular problems, heart problems, but they're less relevant to safeguarding. So I need to be sticking in this session to the way people think, learn and behave, because that's more relevant to the safeguarding arena. Next slide, please, Sarah. So during pregnancy, if a pregnant mum drinks, alcohol will cross the placenta and enter the baby's bloodstream. The baby's processing systems, the liver, the kidneys, are immature and can't process it, and alcohol can enter the brain tissue and cause abnormalities. Alcohol works in two different ways. It's toxic, so in the same way as almost any other drug, or if you're thinking about something like a weed killer, if it touches the cells, if it has contact with the cells, it will cause immediate damage to the cells, but it also has a more long-term damage in that it will interfere with how cells reproduce, how cells develop, and that can cause problems as well. The brain is going to evolve throughout pregnancy. You don't start out with a completed brain. So the brain evolves during pregnancy. So the impact of alcohol will vary in its long-term consequence depending on where the brain is at its stage of development, where alcohol has contact with the brain. So the alcohol can be significant and harmful at any point from conception all the way through to delivery, because the brain development changes through all this time. You wouldn't give alcohol to a newborn baby. We know that alcohol in young children can have a significant effect on brain development, and the brain carries on developing all the way up to the age of 25 plus. And so alcohol, particularly during pregnancy, is damaging at any age. You can't say, well, we're in the third trimester now, the brain's developed, it's safe. It just isn't. And if we go on to the next slide, Sarah. There was a relatively recent study in Glasgow that looked at the meconium of newborn babies, so that's the sticky poo that comes out straight after birth, and 42% of samples showed evidence of the mother having had alcohol during pregnancy. And if you think that's a huge number, think back. I know there's a lot of women and potentially mums on the call. I know I had the odd drink in pregnancy. If I was at a wedding or at a party, I'd have a glass of champagne, or I'd have a glass of wine at a dinner later on. That would count, that would be enough. I know one of my colleagues had a bleed early in pregnancy and thought she'd lost the baby, and she went and she got smashed that night with her husband. That would be enough to meet criteria for alcohol exposure during pregnancy. You don't need to be an alcoholic. You don't need to be drinking every night. You don't need to be drinking large quantities on a regular basis throughout pregnancy. Any alcohol in pregnancy is enough to potentially cause a problem. So it's estimated that about 3.2% of babies in the UK are affected by fetal alcohol spectrum disorder, which is a small number compared to the percentage of mums that are exposing their babies to alcohol. So 42% of mums, 3.2% of babies. So it doesn't sound like a huge number, but if you think that's 3 or 4 times the rate of autism, and if it is about 3.2% of babies, we're going to be looking at over 300,000 children across the Black Country who are affected by fetal alcohol spectrum disorder. And we know that a higher proportion of children in care are affected as well. They will be the ones probably whose mums drank more, whose mums were a bit more chaotic potentially, where there were neglect or physical abuse or domestic abuse factors. So we know that in those populations there are more mums who drink alcohol. So we see it more in children in care than in the general population, but it's definitely present in the general population as well. If we can go on to the next slide, Sarah. So as we said, depending on where the brain is in its development when the insult from alcohol comes, that will impact on what the outcomes are throughout life. We know that about 90% of children and young people with FASD will experience mental health challenges over their lifetime. We know there's a higher rate of suicidality. We know that a lot of children and young people with FASD will also have diagnoses of ADHD, oppositional defiance, conduct disorder, psychotic disorders. We know that if you look at the school-age population who are expelled from school, there's a higher proportion of children with FASD in there, and they're well known in the youth offending and in custodial accommodations. These children and young people are more prevalent there. They may demonstrate inappropriate sexual activity, and they may go on and have drug or alcohol problems themselves. So you can see that these children, young people, are impacted for life. The cost of the mental health problems, the cost of the offending and the judicial system, the cost of their reduced education attainment, and the harm that they do to themselves and others costs the country a fortune in terms of a monetary expenditure, but for the children and the families it has a huge negative impact on their lives. Next slide, thank you. So if we look at the fetal brain development, you can see how it changes throughout the pregnancy. So in the first trimester, in the first 10 weeks or so of life, that's when the nerves are starting to develop, when the brain is starting to develop and differentiate into brain tissue rather than heart tissue or lung tissue or anything like that. Over the next few weeks, the number of nerves within the brain multiplies, and then there's what's called migration, so that the brain continues to develop. The nerve cells themselves move around, move into the right places and form the brain structure. Towards the end, in the second half of pregnancy, that's when the nerves start communicating with each other. And then in the third trimester, the brain kind of tidies itself up a little bit. It forms the folds, it forms its more complex structure, and it starts to differentiate further. So you can see that if during the first trimester there's alcohol that kills cells off, it can have a big impact on the development of neurons. Towards the end, it's looking more at the speed that the nerves carry their signals and the way they communicate with each other, and what happens there. So anywhere in between there will have an impact on what's happening to the brain when alcohol is in contact with the cells. Next slide. So the frontal lobes are the front bits of the brain above the eyes, and that's where all your thinking happens, your executive function, your memory, your learning, your processing, everything like that happens in the frontal lobes. If you have the parietal lobes are more around to the side, if there's damage there, it's thinking about spatial awareness, it's thinking about logic, it's thinking about your maths and your problem solving abilities there. And then there's problems with the way the different parts of the brain connect and talk to each other. So you've got your corpus callosum, which is where the two sides of the brain talk to each other. If there's damage there, there's different problems again. So it's impossible to have a one size fits all depending on what point the damage occurs during pregnancy, how much damage occurs, and the impact of postnatal life as well. Okay, and the next slide, Sarah. So I guess what I'm trying to say is that there is no safe level of alcohol in pregnancy and no safe time to drink alcohol in pregnancy. And you can get two different subtypes. You've got FASD, fetal alcohol spectrum disorder, with sentinel facial features, and you've got FASD without sentinel facial features. And the main difference between the two is the point at which in pregnancy alcohol was consumed. So the face develops in the first trimester, in the first third of pregnancy, and if there's damage at that time that affects facial development, children who are exposed to alcohol in that time can have a typical appearance. So Sarah, if we can have the next slide. These are children who have the facial features of FASD. So you have small palpable fissures, so the width of the eyes is smaller than normal. They look quite round in a lot of cases because they are narrower in comparison to their height than in the general population. They have what's called a smooth philtrum, so the little groove that comes from the nose down to the centre of the lips. In most people, it's heaped, and in these children, it's smooth across it. And you'll notice as well, they all have quite a thin upper lip. They're not full lips. They don't look as though they've got much filler in there. So these are typical facial features that you get with Down syndrome, and there are scales and measures. You can't just look at someone and say, oh well, you've got FASD. There's scales and measures to compare to the normal population, and you have to reach the criteria there. It's not something that I could look at a child in clinic and say, you've got the facial features, therefore you have got. I would still have to take the measurements to confirm it. But if you see a child that looks a bit like this and has difficulties with behaviour, with learning, with processing, maybe with speech, who's small, these might be indicating FASD with sentinel facial features. If the alcohol exposure occurred after the face has developed, you're going to have FASD potentially without facial features because the face is already set in its development by that stage. And the next slide, Sarah. So I think I've already said there's no safe gestation to be able to drink, and there's no safe quantity to drink. And we're not going to be doing tests on people and studies on people to see what the level of alcohol is needed, because the risks of exposing pregnant women to alcohol are too high to risk saying, is it 3 units or 4 units that we need? We don't want to risk the babies for doing that. So when we're looking at other impairments, there's 10 potential neurodevelopmental, what we call domains, that we look at. So to have a diagnosis of FASD, you have to have impairment in 3 of these 10 domains, together with the history of alcohol exposure. So I'll go through the 10 separate domains as well, so you can see all the different neurodevelopmental impairments that we get in FASD. The first one we can look at is the brain structure. So you can have a small head. So we're very good as doctors in babies and infants in measuring the head and plotting it on charts. And if the head is below the 3rd centile, so if we have 100 children, 100 babies with a particular birthday, 3 out of 100 measurements in that stage will be below the 3rd centile. So that would count as abnormal. We can't just look at a child and say, oh yes, your head looks small, therefore you've got a small head, and it fits with FASD. We'd have to be measuring the head, plotting it on charts and having a look. But there's also structural brain abnormalities, So if we did an MRI scan of these brains, we might be looking at particular areas of the brain which might be abnormal. We might be looking at the folds of the brain which might be abnormal. We might be looking at some areas which are smaller than we'd expect, and the brain tissue would be poorly developed. Sometimes if there's a seizure disorder, so if someone's got epilepsy but we don't know why, or if there's a cerebral palsy, a visual impairment, a hearing loss where other causes have been excluded, and this is a result of brain development. This could also be as a result of FASD. So as I said, it's 3 of the 10 domains that are needed to be positive. So you might have children with these abnormalities, but they don't have another 2 domains ticked, so they don't meet FASD on their own. Or you might have children with FASD who don't meet these criteria. So if we move on, Sarah, to the next mental impairment, we're looking at the motor skills of children. So you might find that these children have difficulties with their motor skills, their precision, their ability to use a pen and paper, their ability to thread beads when they're younger, their ability to use a knife and fork might be reduced. Their gross motor skills, their ability to ride a bike, to swim, to run in a coordinated fashion, to do a cartwheel, might be affected by their neurodevelopmental impairment. And we can't just, again, do that from history. It has to be a validated assessment, so it's got to be a professionally undertaken assessment with a score that comes out at the end of it, and the score again has to be below the 3rd centile. These aren't assessments that I can do as a doctor. For the neurodevelopmental motor skills impairments, it's usually occupational therapists who will undertake the assessments that will be structured, be validated, and give the overall scores. Next slide, Sarah. Cognition, so your learning and thinking. This can be impaired as well. These children may have a low IQ. They may struggle with verbal and non-verbal reasoning skills. They may take a longer time to think and to process questions, to come up with answers, to read their questions and work out what's going on, and their working memory is going to be reduced as well. Again, we have to check this with standardized tests of cognition and intelligence. So we're looking at specific IQ scores or assessments by teachers and educational psychologists that will give a definite diagnosis of a centile below the 3rd centile in cognition, in IQ, in reasoning skills, and in memory. Next slide, Sarah. The next one is in language. So this is both receptive language, your understanding of language, and expressive language, so your use of language and your speaking. These are assessments that will, again, need to be undertaken by speech and language therapists, and very often you'll find a discrepancy between their receptive and expressive scores. So they can be really good with their verbal language, they can be really expressive, they can sound quite mature in their use of language, they can sound quite intelligent in their use of language, but their receptive language is reduced. They don't always fully understand what's being said to them, and their processing skills are slow. So someone might sound completely in line with their peers in the way they're using language, but their actual understanding of what's going on around them is much reduced. You can see this is just domain number 4 out of 10 as well. So you might have ticked off these 3 or 4 domains that we've gone through and said, yes, there's difficulties there, yes, there's difficulties there, yes, there's difficulties there. We've got a history of alcohol, in which case the rest of the domains, it doesn't matter whether they meet the criteria or not in these domains, or it may be that they're completely fine in these domains, but they meet the criteria in 3 of the domains we haven't looked at yet. So it does give completely different pictures of young people with FASD. Okay, next slide, Sarah. In their academic achievement, unsurprisingly, if their language use is reduced and their IQs are reduced and their memory is reduced, their academic achievement is going to be below standard. So this might be reading, writing, maths, literacy, and again in standardised tests we're looking at scores below the 3rd centile. And we might find that someone's cognition is absolutely fine, but they may struggle with their academic achievement, and you might find that their maths is amazing but their reading is really poor and there's no explanation for it, and that might be a result of FASD as well. When we look at someone's memory, we might be looking at their overall memory, their verbal memory, or their visual memory, and again it's standardized testing for this, and this would come from psychologists or educational psychologists. Again, it's not something I can do in clinic, and there's standardized testing that works for this. There's not a lot else to say about memory, but when we're thinking about attention, it might be selective attention, so focusing on something in particular they struggle with. It might be being a typical man and trying to focus on more than one thing at the same time. Sorry to any men in the audience. If you're trying to focus on 2 things, that can be difficult. If you're trying to switch from working on something over here and then suddenly working on something over there, switching between 2 different stimuli can be really difficult. Or holding attention for a long time, sitting through a 2-hour exam, reading a whole book, writing a whole essay might be almost impossible. And this usually shows itself as problems with concentration, work organisation and focus. It can also show as impulse control and hyperactivity, although that tends to be looked at in the executive function area of assessment rather than the attention area. So this is particularly around concentration, but you can see how a diagnosis of ADHD with poor focus, poor concentration, hyperactivity and impulsivity can be part of FASD as well as being diagnosable as ADHD. Next slide, Sarah. So the executive function includes your impulsivity and your hyperactivity, and again there's particular tools that will measure for this above and beyond the ones we use for ADHD. So on their validated tools we use Vanderbilt questionnaires, QB testing for ADHD. The examples that the national guidance gives don't include those, but it's very similar to ADHD, and we often see both FASD and ADHD together. And the next slide, Sarah. Affect regulation, so that's your mood. So these might be young people who have low mood depression disorder. They meet the criteria for a diagnosis of depression. They may have separation anxiety, elective mutism, social phobias, panics. They might be really anxious. They might have conduct disorder and oppositional defiance disorder. So a lot of this will be where we're seeing children involved in the youth justice system, a lot of children involved with CAMS with their mental health problems. Exploitation can be a part of this as well, and and we'll see it in younger children, separation anxiety, maybe at the school gates, and their attachment with parents. And finally, with the next slide, Sarah, their adaptive behaviour, their social skills and their social communication, which is where there's a crossover with autism. But these are life skills enabling a child to live independently, and how will they cope with tasks. This might be abstract thinking, it might be your social skills, your social communication, your empathy, your interpersonal communication, your ability to make friendships, your ability to make relationships in workplaces, your ability to manage yourself, your social appropriateness, your hygiene, your ability to remember to go shopping, money management, and being generally organised and able to live an independent life can be affected by the FASD. Even if you have normal cognition, normal learning, this can still be an issue for you. Okay. So, as I've said, for a diagnosis of FASD, we need to have a confirmed history of antenatal alcohol exposure. So, if a child is referred to me for consideration of possible FASD, the first question I'm going to be asking mum is, did you drink in pregnancy? Invariably, the answer comes back as no. And if it's not documented in antenatal notes, if it's not in the GP records, if it's not in the health records, I can't make a diagnosis of FASD no matter how many domains, no matter their presentation. If there's no confirmed antenatal exposure to alcohol, the answer is no. And I will ask, what about before you knew you were pregnant? Because sometimes people will stop drinking once they have a positive pregnancy test. And I'll ask, what about at weddings and parties and that sort of thing? If it's Christmas, would you have had a glass of wine at Christmas? But invariably, the answer I get from parents there is no. The other thing we need is 3 of the 10 domains that I've just gone through need to be ticked off. So it's looking for that information from different multi-agency professionals. For a diagnosis of FASD with sentinel facial features, I don't need the confirmation of alcohol during pregnancy. If you've got the facial features, that can only happen with exposure to alcohol. So if I've got that and I've got the evidence of impairment in 3 or more of the domains, I can make a diagnosis of FASD with sentinel facial features. I'll still ask about alcohol in pregnancy, but you don't need it if there's the facial features. So if we look at some examples, if I think about Lewis, a 15-year-old boy who was struggling in school, he had poor focus, poor concentration. We were thinking about possible ADHD with him. He'd been in trouble with the police, he had issues with his conduct disorder, and we knew that his verbal memory was good. If he was told something, if he heard something, he could remember stuff. If stuff was written down, absolutely no chance of him remembering anything. Exams were really difficult for him. There was a history of alcohol in pregnancy for him, and with the scores that we got from educational psychologists and from psychology and CAMS, together with a history of alcohol, we were able to give a diagnosis of FASD for him. If you look at the difficulties he's got and compare that to 14-year-old Amelia, who comes across really engaging, really mature in her language, but takes a while to think and process what's being asked of her and can be literal in her understanding. She's really impulsive. She's found herself in situations she regrets, and she's got some depression, diagnosable depression with some self-harm. That is a very different presentation to Lewis. but with a history of alcohol exposure in pregnancy for Amelia, she would also meet the criteria for a diagnosis of FASD. Tiana, 8-year-old girl, again a completely different presentation. She's got a hearing impairment with cochlear implants. She's struggling with her academic progress, and she doesn't get the social rules in school. So much of this could be explained by the hearing impairment, but we have got no underlying cause identified for the hearing impairment. There's a history of alcohol in pregnancy. She meets the criteria in the standardised tests for her learning and her social progress and social communication, and that would meet the criteria for FASD. So if you compare her to Amelia and Lewis, she's a very different presentation but still meets the criteria. And then Jamie, 3-year-old boy, small head, seizures, abnormalities on an MRI scan, delayed speech and language, delayed motor development, a history of alcohol in pregnancy. Again, a very different presentation to Lewis, Amelia and Tiana, but would also meet the criteria. So you can't look at one child and say, no, they don't fit in, they're different to the other children that I've seen with FASD, because all of these, although they're very different presentations with a history of alcohol in pregnancy, would all meet the criteria. They tend to have a very spiky profile. They have their strengths. In general, they're articulate. They have an engaging personality. They're very creative. They like their practical subjects. Rote learning and long-term memory are pretty good. It's getting it there. They struggle to achieve milestones, including things like toilet